So today we are going to start this gastroenterology. Okay, so the topic for today is gastroenterology. Okay, so now this is the gastroenterology chapter. So we will have esophageal disorders, we will have the stomach disorders, we will have intestinal disorders. Um, so we are going to do everything related to GIT here. Liver is also included in the gastroenterology. So here we are seeing a first is esophageal disorders. So esophageal disorders, what are the esophageal disorders? Is whenever there's any esophageal disorder, the most common symptom will be the dysphagia. Dysphagia is actually nothing but difficulty swallowing. It is an essential feature of most of the esophageal disorders. Alarming symptoms. What are the alarming symptoms for the esophageal for the esophageal disorders? It is going to be the blood in the stool, anemia, weight loss. So how is this blood going to go? So actually what happens is this blood in the stool is called as a melena. It is black in color. So that is melena. If it is black in color, it is called as a melena. Anemia. Anemia means loss of blood from the GI tract and weight loss. If any of the symptoms are present, perform an endoscopy. So first you have to do is perform endoscopy if these three other risk factors. Weight loss has a limited value when diagnosing the esophageal disorder since it is seen both in dysphagia and odynophagia. So weight loss means weight loss occurs when the patient is not able to eat food. So what is happening here? There's difficulty swallowing dysphagia, but the pain while swallowing is called odynophagia. Okay, hiatus hernia. Okay, so now the next thing is actually hiatus hernia. Hiatus hernia is actually the protrusion of the upper part of the stomach into the chest. So it is due to the obesity. The causes is going to be obesity. What will obesity do? Obesity is going to weaken the diaphragm. It is associated with the heartburn, chest burn, dysphagia. Symptoms can be distinguished from the GERD. So symptoms are like almost similar, but there can be some minor differences between the GERD and her hiatus hernia. So hiatus hernia you see in the obese people, the people who are like very very fat, obese people. In that people we see hiatus hernia. Diagnosis: how do you make the diagnosis of the hiatus hernia? On the endoscopy, we see it on the endoscopy or on the barium study. So this is the esophagus here from the mouth, and the food directly goes into the esophagus. So esophagus is the connecting tube. From the esophagus, it goes into the stomach. So this is the diaphragm. These lines are the diaphragm, and on the right side, it is going to be a liver. Stomach is on the left side. So here, what is going to happen in the hiatus hernia? There is the top portion of the stomach, top part of the stomach is going into the esophagus. So see, this is esophageal hernia. This is sliding type of the esophageal hernia. So what is the best initial treatment? Is actually if the yes. So here it is due to the obesity. So the first thing you should tell the patient is do the weight loss and put on 1 millimeters. If the symptoms persist, then you have to do a surgical correction. Why do we don't want to do surgical correction? Because it's going into the esophagus area, so it will cause like strangulation. So this area can undergo some necrosis and this can die also. This area, so that's why we want to do surgical correction in the people who are not responding to the treatment. Essence fundoplication. Paraesophageal hernia is more likely to need surgery than the gastric valvulus obstruction, strangulation, or perforation. Achillea. Achillea. What is achillea? It is inability of the lower esophageal sphincter to actually relax. Lower esophageal sphincter to actually relax. This is due to the loss of the nerve plexus of the lower esophagus. Now, within the lower esophagus, the etiology is actually not clear. It is actually aperistalsis. That means there is no peristalsis in the lower part of the esophagus. So the patient is usually the young patient, less than 50 years of the age. Less than 50 years of the age, progressive dysphagia is there dysphagia to both solid and liquid. So whenever we see dysphagia to both solid and liquid, then it is actually a motility disorder. Motility disorder means eclasia cardia or diffuse esophageal spasm. So this thing should come in our mind. Dysphagia to both solids and liquids. Diagnosis: how are we going to diagnose? So first of all, we will do is barium esophagogram. It will actually show a bird beak appearance. Manometry will actually show the pressure changes. It will actually show us that the lower esophageal sphincter is actually not relaxing. So now chest x-ray will actually show the abnormal widening of the esophagus. Chest x-ray is going to show abnormal widening of the esophagus. But chest X-ray is neither very sensitive or nor very specific. Upper endoscopy will actually show a normal upper GI endoscopy will show a normal mucosa in eclasia. However, endoscopy is actually important because it to exclude the malignancies. In the esophagus, barium swallow are like acceptable to do first in the most of the patients. Although the although radiological tests always lack the specific CTA for the endoscopic procedures. So even though nowadays endoscopy is there, but still we prefer barium studies because this is like a very this is comparatively like very cheap also, and this can be done as a first line for many things, especially when there is no such setup where endoscopy is present. So this is the bird beak appearance. This is the esophagus. So here you can see that there is tapering of the esophagus. Normally it should be like a complete cylindrical shape. So we can see here this narrowing. So this is eclasia cardia. So what is the treatment here? Treatment here is a simple mechanical dilatation. So either you do mechanical dilatation of the esophagus, there is no real cure. Nothing can restore the normal function of the missing neurological control. You can't put the artificial neurons here. So here what we can do is we can manually dilate this. So the treatment is called as a pneumatic dilatation. The name of the treatment of mechanical dilatation is pneumatic dilatation. So with the air we are actually dilating this. Placement of an endoscope that allows the device to be inflated, that will be large, and that will enlarge the esophagus. In less than 3% of the patients, this treatment will actually cause other perforations. It is safer than the surgery, but it is like less effective. Choosing between the two procedures may be difficult also. So surgical setting is like the myotomy. It's just like cutting the muscle. It's a bit botulinum injection. This is also there. This is to relax the lower esophageal sphincter. The effect actually wears off, but if you are using the Botox injection here, it will wear off in 3 to 6 months. This requires repeated injections. In the esophagus, the only cancer and Barrett's esophagus are diagnosed by the biopsy. You don't take biopsy for everything for the esophageal things. You do it only for the cancer to rule out the cancer and the Barrett's esophagus. So, what is Barrett's esophagus? It's a precancerous condition. Okay, esophageal cancer. What is the most likely diagnosis? See, esophageal cancer, like any cancer, this is seen in the old age. So the age will be like the more than 50. Dysphagia is there. So the rule of the cancer is like first either is dysphagia to the solid, then to the liquid. So it progresses slowly and slowly because the tumor increases in the size slowly. Okay, so associated with the prolonged alcohol use is there, so smoking history is there, more than 5 to 10 years of the GERD will be there. So the single word is progressive, like progressive is like very, very important and important to its veil cancer. Okay, now diagnostic testing. So what do we do with the endoscopy? Endoscopy is actually indispensable since the only biopsy it can diagnose the cancer. Barium may be the first line also. Initially first what we can do is barium swallow we can do. Then the CT and MRI just for the staging. We want to see the extent of the tumor. If they are not enough to diagnose esophageal cancer, PET scan to see. Where it has spread. For cancer, radiological test is actually never the most accurate test. Local disease is like resectable thing. So if it is a local thing, it's like a resectable thing. But widely metastatic disease is not. The treatment is actually nothing but a surgical resection. If there is no resection, that means there is no cure. So in addition to the surgical resection, we do is chemotherapy and the radiotherapy also. For the lesion that cannot be resected, stent placement can keep the esophagus open. So what we can do is a stent placement. This is for the cancerous patient because they have a lot of tumor. So just for the palliative treatment, we can do this. Esophageal spasm. So there are two types of the esophageal spasm. One is diffuse esophageal spasm, and other is actually nutcracker esophagus. Both are clinically indistinguished, both present with a sudden onset of the chest pain unrelated to the exertion. Initially, it is impossible to distinguish them from an atypical coronary artery spasm or unstable angina. Symptoms, it can be like precipitated by drinking cold water. Drinking out of the cold water, sudden severe chest pain will be there. Normal EKG is there, normal stress test is there, normal esophagogram or endoscopy. Like everything is like normal here, but the patient is having diffuse esophageal spasm. So here diagnosis for the diffuse esophageal spasm and nutcracker esophagus. It is done with the manometry. So what manometry? So manometry is like a pressure change. So it records like a very high abnormal contraction. So this is the esophageal spasm seen in the barium study, which shows a corkscrew appearance at the time of the spasm. So how do you treat this diffuse esophageal spasm or the nutcracker esophagus? So first line is calcium channel blockers. So if calcium channel blockers are not using, then we can use tricyclic antidepressants and sildenafil also, and nitrates. Calcium channel blocker nitrates, we should remember, proton pump inhibitors in some cases. Eosinophilic esophagitis, it is the in the patient will actually have like a swallow, difficulty swallowing, the food impaction, heartburn is there. So eosinophilic. So if you see in the conditions wherever there is a very high eosinophil count, like asthma or the allergic diseases, endoscopy is going to show the multiple concentric rings. In the eosinophilic esophagitis, what we will see, we will see the multiple concentric rings. So the most accurate thing is you do the serum eosinophil level, you see how many eosinophils are present. The first initial test in treatment is actually proton pump inhibitors, yes, and we have to eliminate the allergic food. Okay, so if whatever the food patient is allergic to, we should actually remove it from the diet. If there's no response, then we can use steroid inhalers just for topical use, just for some short duration, just to suppress the inflammation and the other thing. Infectious esophagitis. 33-year-old man diagnosed with the AIDS comes to the emergency department. The pain while swallowing it has become progressively worse over the recent weeks. The pain is actually only when swallowing. Okay, so it's only there when swallowing, and sleep count is less than like 50. The patient is now currently taking any medication. What is the most appropriate next step? So this is infectious esophagitis. So it is due to the AIDS. So here, what do we do here? In AIDS, what is the most common infection? It is going to be Candida. Candida, that is oral thrush. So for that, we will actually use oral fluconazole. The most commonly asked infectious esophagitis question is about the esophageal candidiasis in the person with the hereditary AIDS. Oral candidiasis, the thrush need to be present in the esophageal candidiasis. Does not automatically follow from each other, although other function of the cytomegalovirus and the herpes can cause esophageal infection. But 90% of the esophageal infections are due to the AIDS are by the candida. So, in 90% of the esophageal infections in the HIV patients, AIDS patients, it's going to be candida only. Empirical treatment is going to be the fluconazole. This is the best course of the action. If this doesn't help, then we have to do is perform endoscopy. The statin, if it's not responding to oral fluconazole, then the statin can be used for oral candidiasis. If there is like a swish and swallow, there's a form that's not sufficient to control the esophageal candidiasis. IV amphotericin is like very for very very severe thing if it's not responding to anything. The following pills can cause esophagitis. So doxycycline like tetracyclines, bisphosphonates like alendronate, alendronate, desidronate, alendronate, potassium chloride, KCl, potassium chloride. So in Canada, where do we use potassium chloride? We use this potassium chloride tablet forms for emergency use near whenever there's a nuclear reactor nearby. So we use it for the way it is reserved for that. And that can also cause esophagitis. Tetracycline, bisphosphonates, and KCl. So first of all, what we have to see what is the cause of the dysphagia. If dysphagia, if the and the sleep count less than 100, so yes, then you have to start fluconazole. If it is not responding to fluconazole, what are you going to do? We are going to add antiretroviral therapy. Antiretroviral therapy we are going to add. So if this is no improvement with the fluconazole, then we do is endoscopy with the biopsy. Okay, so biopsy is going to show us everything. If the biopsy is actually showing linear ulcers, large linear ulcers, then it's going to be cytomegalovirus. So the treatment of cytomegalovirus is going to be anticyclovirus. And if there's any small alteration here and there, then that's herpes simplex virus. So then we have to give acyclovir. Rings and the webs, this is like super important. So the Plummer-Vincent syndrome, this is going to cause the web, and Sasaki ring is going to cause a ring. It's going to cause it's a vascular ring. Okay. So both will cause dysphagia. The Sasaki ring is caused by the acid reflux. Okay. So this is associated with the Harris hernia scarring as well as tightening. So there is going to be intermittent dysphagia, like sometimes the patient having dysphagia. Promovin syndrome, it is in iron deficiency, anemia. It is more proximal. It's more proximal. That is, it is in upper part of the throat. Okay, upper part of the esophagus. It is seen. The proximal part and the Shizaki rings are easily detected on the barium studies. So rings are actually easily detected in the barium studies of the esophagus. Treatment Shizaki ring. You have to use pneumatic dilatation of the endoscopy procedure. Dermovention syndrome. How do you treat? I have the iron replacement at first, and which may lead to resolution of the lesion. Sasaki rings. It is a stick house syndrome, a dysphagia from the solid food associated with the Sasaki ring. So here, this is like a vascular ring. You can see that there is narrowing present. Sasaki ring is present on the lower side, whereas the Plummer-Vincent syndrome is present on the upper side. Zenker's diverticulum is actually outpouching on the posterior phalangeal constrictor, so the patient will have dysphagia, severe halitosis, the difficulty swallowing is the severe halitosis, the bad smell is there, regurgitation of the food particles at night will happen. So at night patient will likely sit up, and the patient is like having a severe bad smell from the mouth. So the patient can also have aspiration pneumonitis when the contents of the diverticulum end up in the lungs. So how are you going to check for this Zenker's diverticulum? We are going to do is barium study. We are going to do exactly barium study. So repair exactly means the surgery, and there is actually no medical treatment for that. Tape do not answer the nasogastric replacement or upper GI endoscopy. These are like dangerous, especially in the people with the Zenker's diverticulum. Yes, so you should never give the patient nasogastric tube or upper endoscopy, because this can actually go directly in the pouch and this can rupture the pouch. So yeah, perforation is the complication. Scleroderma we saw in the rheumatology thing. So scleroderma can also cause difficulty swallowing. And so this patient will have symptoms of the reflex and history of the scleroderma. Their progressive systemic sclerosis. Manometry is indicated. Manometry will tell us in children the pressure changes. So it is going to show the decreased lower esophageal sphincter. Is there an inability to close the lower esophageal sphincter? Treatment is actually going to be the proton pump inhibitors. Treatment is of the scleroderma into proton pump inhibitors, and the response is actually simply one of the mechanical immobility of the esophagus. So it's just like in scleroderma, there's actually slowing this fibrosis everywhere. So here also this fibrosis. So here the esophagus is not moving much here. So what is the thing you do? You do give proton pump inhibitor. This is because of the reflex also, right? Yeah. Manometry is the answer for achalasia cardia, diffuse esophageal spasm, and scleroderma. So everywhere you are going to check the mobility. Memory V-stage, it is like just a simple mucosal tear, it is like just like a simple cut on the mucosa of the gastroesophageal junction. So here Mallory Wistia is present as upper GI bleeding. So upper GI bleeding, what is the most characteristic thing? It is going to be BU and creatinine is going to be elevated. Melina will be there, anemia will be there. So memory based here, what are you going to do? You are going to do. So why is this memory based here occurring? Whenever the patient is actually having very severe repeated vomitings and retching, so that time memory based here is a repeated retching is followed by the hematemesis. That is a lot of red blood is coming, bright red blood is coming, or a black stool. That is melina is there. There is actually no dysphagia. There is no specific treatment. It will resolve spontaneously. So because it's just a cut on the mucosa, so there's no need to worry. For the severe cases, persistent for the severe cases, what we can do is persistent bleeding. The epinephrine injection can be given or electrocorticoid membrane to stop the bleeding. Before we syndrome, it is like the full penetration. It's going to transmural, like all the layers of the esophagus are going to be cut here. So this is like very very dangerous. Before syndrome is like very dangerous thing. So this is the difference. Before is going to be the full penetration of the esophagus. Melogy base, as I told, is just going to involve the upper single layer of the mucosa. Now coming to epigastric pain. So here epigastric pain, it is actually nothing but as a part of the abdominal surfaces located beneath the xiphoid process and the upper two sets of the ribs. It is actually above the umbilicus. So the pain in the epigastric area is actually like common. So 24% of the population at some point in the life will have tenderness in this epigastric area. Uh, the pain is actually the most common complaint or the sensation restricted by the patient. It's not the same thing as tenderness. Tenderness is a physical finding which a clinician finds, right? Mm, so the pain is the patient's complaint in his own language. So here, 44 years old woman comes to the reporting. It comes in reporting the pain in the epigastric area for several months. She denies nausea, vomiting, weight loss, or blood in the stool. On physical examination, no abnormalities are found. Physical examination, no abnormalities are found. What is the most likely diagnosis here? So here the most likely diagnose epigastric pain. Mm, oh, just epigastric pain. Is it for several months? She denies nausea, vomiting. Okay, on physical examination, no abnormality. Just chronic. So it means chronic epigastric pain. So what is the reason for chronic epigastric pain? It is first most common cause is GERD. So GERD is like dyspepsia also, right? That's why we are calling it as a functional dyspepsia. In the hospital, you will see far more patients with ulcer, pancreatic disease, and cancer. However, those are the ones who are admitted. But the functional dyspepsia, it is like just like a normal GERD thing, which will have epigastric pain. And so functional dyspepsia is virtually never a reason to be admitted. So almost everyone can even have a GERD some point of the time. So it's like very very simple. It's not related to the patients who get admitted. Pain worse with the food, it is so this table is important. So pain worse with the food, it is going to be gastric ulcer. Pain better with the food, it is going to be duodenal ulcer. If there is a weight loss, then think about the cancer, gastric cancer. If there is tenderness, if there is tenderness of the abdomen on when you are palpating, but this you are getting tenderness. So that means that this is a pancreatitis, either acute pancreatitis or the chronic pancreatitis. Bad taste to cough for the hoarseness of the voice. So it can be GERD, diabetes and bloating. If a patient is diabetic and a patient is having very bad bloating, then it's gastroparesis. If there's nothing and so it's non-ulcer dyspepsia, just a normal dyspepsia. Okay, so patient hospitalized with epigastric pain are far more likely to have ulcer, biliary disease, pancreatic disease, cancer, and gastritis with bleeding. So endoscopy. Endoscopy is the only way to understand the epigastric pain. Whenever patient is coming with the epigastric pain, so we can do is endoscopy. Radiological and the barium tests are the modest accuracy at best, but you cannot do biopsy while this testing. Okay, only endoscopy is going to give the precise diagnosis. So this is like super important. Like in endoscopy, you are not just seeing, you are seeing, you are also taking a sample from the lesion. So in the esophagus, barium study is actually a good place to start with the testing, but in the stomach, the barium is actually very poor. Okay, so upper right quadrant, whenever the patient is coming with the upper right quadrant pain, so we have to remember this table. It's like this is like very, very super important. So if the patient is actually having right upper quadrant pain, so it's going to be cholecystitis, biliary colic, cholangitis, perforated duodenal ulcer. Perforated duodenal ulcer. Then if it is left upper quadrant pain, then it is going to be splenic rupture, the splenic flexural syndrome. Yes, so here in the left upper quadrant, spleen is there, and the splenic flexure of the intestine is going to be there, and the right lower quadrant is going to be appendicitis, Meckel's diverticulum, ovarian torsion, ectopic pregnancy, cervical diverticulitis. left lower quadrant, it is going to be sigmoid colon, it is going to be sigmoid diverticulitis, volvulus can be there, diverticulitis can be there, ovarian torsion can be there, ectopic pregnancy can be there. So ectopic pregnancy and the torsions are there in both the sides because ovaries are there on both the sides. So ectopic pregnancy and ovarian torsion are there in both the sides. On the right lower, you will have celiac diverticulitis. On the left, you can have is sigmoid diverticulitis. In the epigastrium, you get the pain from the pancreas and the aortic dissection and peptic ulcer disease. Treatment of the epigastric pain, it is actually starts with whenever there is a proton pump inhibitors, you are going to get proton pump inhibitors. The various mechanism medications are all having the equal efficacy. Additionally, H2 blocker, it is like the H2 blocker, cimetidine, famotidine is less effective, but works in 70% of the patients. So, liquid acids are also available. So, they have the same efficacy. Cimetidine, famotidine, nizatidine. Misoprostol is always the long answer. Misoprostol is an artificial prostaglandin analog. It is derived to prevent the NSAID-induced gastric damage. So when proton pump inhibitors arrive, misoprostol becomes absolute and the wrong answer. Mr. Septic does not test the dosing. So GERD, what is happening in the GERD? GERD is actually inappropriate relaxation, otherwise which is being treated caused by the acid contents of the stomach. As mentioned on the stomach, content of the stomach that come up to the esophagus and the symptoms of the GERD are actually worse with the nicotine. It's going to be worse by the nicotine. That means smoking, alcohol, caffeine, chocolate, peppermint. These are going to get worse with this. Okay, yeah, nicotine, alcohol, caffeine, chocolate, peppermint, late night meals, obesity. So these are going to make it worse. There's no unique physical finding of the GERD. GERD is actually complex and most often diagnosed with the diagnosis is by 24-hour pH monitoring. So this 24-hour pH monitoring actually confirms the diagnosis. Symptoms of GERD can be like a sore throat or a bad toe, a bad taste, metallic taste, hoarseness of the voice or the cough. GERD may also show redness, erosions, ulcerations, strictures, and paresophagus. What is the most likely diagnosis? GERD is actually the answer when you see epigastric burning pain and radiating to the chest. You do not have to do all of these extra symptoms in order to answer the GERD as a most likely diagnosis. So GERD is like very, very simple. You can see in almost all the patients GERD. 42 years old man comes to office with several weeks of the epigastric pain radiating to under the chest. So see gastric pain radiating to the chest. It's going to be yeah, it's going to be GERD. That's actually worse after lying flat for an hour. He also has a brackish taste in his mouth, sore throat, was next step in the management. This patient clearly has a GERD. So what are you going to how are you going to treat this GERD? We are going to give proton pump inhibitors. So proton pump inhibitors, this is there are two here, lansoprazole and etidine. So we prefer lansoprazole more. Lansoprazole is a proton pump inhibitor. This is like H2 blocker. Ranitidine is H2 blocker. When I used to control the symptoms of the GERD, when diagnosis is like very clear, like epigastric pain going to sternum, bad taste, sore throat, confirmatory test is not required. Just start the patient with H2 blockers, and effective in 70% of the patients, but clearly inferior to PPI. So PPI is the best of all. Proton inhibitor, lansoprazole, omeprazole. Endoscopy does not diagnose a GERD. Brain fellow does show the major anatomical abnormality. Endoscopy will show nothing when there is actually heartburn. Endoscopy is going to be normal in the GERD. Endoscopy is actually indicated Endoscopy is actually indicated when there is actually signs of the obstruction. Is there if there's any weight loss, anemia, is there melena, is there treatment lifestyle modification? First, you have to focus on lifestyle modification like reducing the alcohol, avoiding the alcohol, caffeine, smoking, chocolate, mint. Avoid eating within 3 hours of the bedtime. So just before sleeping, you should not eat the food. Or if you are obese, then you have to lose the weight. Okay, so these are the advice we give the patient. Mild and intermittent symptoms are the liquid antacids or H2 blockers. Persistent symptoms or the erosive esophagitis of the inhibitors all are equally effective. The symptoms are likely unresponsive to the treatment. Surgical correction or anatomical correction to tighten the lower esophageal sphincter. Then it's for application is wrapping the stomach around the lower esophageal sphincter. So essence fund application is wrapping of the stomach around the lower esophageal sphincter. Endo-linked and using a scope to place a suture on the lower esophageal sphincter to tighten it. Okay, so basically we want this girl to get control. Because why are we so worried? Why we even want to go for surgical treatment when it's not responding to the proton inhibitors? So the reason is that whenever there is a GERD, what actually happens is that there's a back so acid from the stomach is actually going into the esophagus. So if this is going to be chronic, then the patient will have a Barrett esophagus. So that is there is actually cancerous condition, cancer of the esophagus. Okay, so Barrett's esophagus it is like a malignant condition. It starts with just with a pre-malignant lesion, then goes into the malignancy. So we really want to avoid that thing. So that's why we can even go for surgery if the patient is not responding to proton per millimeters, H2 blockers, then we can go for surgery. Surgery, what surgery? Nissan's fundoplication, wrapping the stomach around the lower esophageal sphincter. So it's like you're keeping it in, you're fixing it so that it doesn't bend here and there. Here, okay. Okay, Barrett's esophagus. What is Barrett's esophagus? Yes, as I told, a long-standing GERD. Okay, so a very long-standing GERD will actually undergo metaplasia, columnar metaplasia. Columnar metaplasia in is 5 years of a reflex to develop. There's no unique finding on the lab test. Only esophagus endoscopy can actually determine the presence of the Barrett's esophagus. Biopsy is the only way to be certain that the presence of the Barrett's esophagus or dysplasia is there. There is indispensable because the biopsy actually drives the treatment. Columnar metaplasia rather with the intestinal features has the greatest risk of transforming into the esophageal cancer. So columnar metaplasia, the intestinal features greater risk of the esophageal cancer. So first, what do we have to do? Whenever there is a Barrett's esophagus, what you are going to do? We are going to take a biopsy, endoscopy. We are going to do endoscopy, and we are doing a biopsy. So biopsy is going to show us columnar metaplasia. That is the squamous cell is replaced with the columnar cells. Columnar cells are like the cells of the stomach, which are actually incoming and invading the esophagus. So that is like very unacceptable. Barrett esophagus alone here what do we do if Barrett esophagus is actually a pre-malignant condition. So here what do we do is we use the proton pump inhibitors every 3 to 5 years. Then for the low grade dysplasia, for the low grade dysplasia, why we are going to use proton pump inhibitors and endoscopy should be done every 6 to 12 months. Okay, so esophagus, then endoscopy should be done every 3 years, and then if it is a lower dysplasia, then every 6 months you have to do the endoscopy. If it is a higher dysplasia, then you should do is ablation with endoscopy. That means the destroying the abnormal cells with the endoscopy, ablation endoscopy, and photodynamic therapy, radiofrequency ablation, endoscopic mucosal resection. Okay, so gastritis it is inflammation or the erosion of the gastric lining. So it is caused by the alcohol, NSAIDs, H. pylori, portal hypertension. It can be due to the stress like the burns, trauma, sepsis, multi-organ failure like uremia. Also, atrophic gastritis is associated with the B12 deficiency. Gastritis are often present with the GI bleeding but without the pain. Severe erosive gastritis can present with the epigastric pain. Severe erosive gastritis can actually present with the epigastric pain. Severe erosive gastritis will likely have that gastric pain, and acid alcoholism is likely to occur here. GI bleeding can be like a coffee ground emesis, a large vomiting with red blood, or it can be a melena. For gastritis, you cannot answer the most likely diagnosis question with the history and physical alone. There is no physical finding for the gastritis. So gastritis, there is no physical finding present correlation with the volume thing. It is like a coffee ground. Whenever there's a coffee ground emesis, so that means 5 to 10 ml only. It's like very minimal. Goyak positive test, that means blood in the stool, but blood in the stool is actually Goyak positive. So this is important terminology. Goyak positive stool. There is a blood positive stool. Then if the stool is actually showing the occult blood present, that means 5 to 10 ml only. Melina is a black color stool. If there's a black color stool, that means that the patient has 2 to 100 ml of at least the bleed. So whenever there is erosive gas strategy to NSAID or any other reason, so what we are going to do, we are going to do upper GI endoscopy, and the capsule endoscopy is not appropriate for the upper GI bleeding. If endoscopy is one of the choices, so testing for the H pylori, H pylori should be done. You have to test for the H pylori whenever there is actually a GERD. Although anemia can also occur, but there is no specific blood test. Radiological studies are like the upper GI series will not be effective. Okay, endoscopic biopsies are actually the most accurate whenever there is an invasive procedure required, like the endoscopy. When you are doing endoscopy, that time only we can do the biopsy easily. Serology is going to be like a very inexpensive, easily excluded infection, lack specificity. Positive test does not tell the difference between the current or the positive old infection. Urea blood test, it is going to be active infection. It is present in the active infection. Active infection only requires special equipment. H pylori stool, H pylori test is positive 95% of the time. It is going to be sensitive and specific. So you require for the to test for the H pylori, you require the stool sample. Okay, so the whenever the gastritis, you give the proton pump inhibitors, you give the H2 blockers, cimetidine, ranitidine, sulfate, and the liquid antacids are not as effective. Sucralfate is like the inert substance like aluminum hydroxide compound that directly goes in stomach. If the sucralfate is present as an answer of the choice on exam, it's almost the wrong thing. Okay. Okay, melanoma. Melanoma causes the false negative H pylori testing. Okay, so stress ulcers prophylaxis is going to be stress ulcers prophylaxis. So whenever the patient is on the ventilator, you have to get the put on millimeters. Whenever the patient is like stressed, like due to burns, head trauma, is there coagulopathy? Is there that time we have to get the prophylaxis, peptic ulcer disease.